Hello everyone, my name is Tiffany and I'm currently a second semester student who recently finished Nursing Fundamentals. In an effort to broaden my knowledge and skill set for my employer, as well as to find an application to the theory discussed this semester in my nursing courses, I participated in the Geriatric Scholar Program offered by Aspirus Wausau Hospital. Right now I hold two positions at Aspirus. I work both in the emergency department as a clinic assistant and in the Oncology Care Unit as a Certified Nurse's Aide, or CNA. So what exactly does the Geriatric Scholar Program entail? Perhaps you recall the Geriatric Syndrome, an article of discussion in Nursing Fundamentals that focused on several problems common to the geriatric population that are not necessarily characterized as diseases, but rather as problems so prevalent to this demographic that they deserve attention. Considerable evidence suggests poor health outcomes and increased morbidity are specific to their occurrence. Issues such as age-related changes in health, urinary incontinence, pressure ulcers and skin tears, delirium, falls, nutrition, hydration, and oral health were the primary focus. Consequently, the 8-hour program for CNAs and the 16-hour program for RNs focus not only on delineating these specific conditions, but also on how they connect to the ACE model. ACE stands for Acute Care for the Elderly, and it uses evidence-based guidelines to guide the care focusing on patient improvement, staffing, and patient satisfaction. In addition, it also uses the model known as niche. Several speakers, all of whom were employees, spoke on behalf of some of the problems, offering ACE-based solutions and accounts of past and current initiatives. Also, one common theme found in the nursing practice, as you're probably aware of, is that safety is a major area of focus in our clinical and theoretical instruction. So not surprisingly, there were many instances in our discussion this semester where the rationale stressed the safety of the action and the clinical decision. One particular area that touches me personally involves the concepts illustrated in Learning Plan 1 on the importance of remembering the ethical duty of non-maleficence, to do no harm. While our profession carries a lot of autonomy, there too exists risk, something we always need to be mindful of. So, who is an ACE patient? Well, defining characteristics vary, as some facilities suggest patients ages 70 and older, and whether or not the patient lives in the community or under the care of a skilled nursing facility. As I learned, nearly 1/2 to 3/4 of Aspire's patients are classified as ACE patients. As I recall in Nursing Fundamentals, we had a lecture that focused on cognitive and sensory impairments. To avoid redundancy, I will avoid focusing on the physiological details and the common interventions, and instead speak to my personal experiences. Hearing loss is one of the sensory impairments that is equally difficult for the caregiver because being unable to communicate with the patient can sometimes place you in an awkward position. I remember one weekend asking a patient if I could assist him to the bedpan. And, of course, when you have an audience of family members, every action can tend to be scrutinized. Unaware of his hearing loss, I had to adjust my communication style by bending down and speaking in a lower voice next to the unaffected ear. As I mentioned, I really had to change my voice and rate of speech to accommodate to the patient. Remember that hospitals are doing their best and will continue to do their best to accommodate to the aging population, since the baby boomer retiree population is estimated to reach 71 million in the next 15 years. Even though it is difficult to set aside the time needed for communication, especially in a busy hospital setting, it is important to speak slowly, but not so slowly that you sound condescending or as if you're challenging their mental capacity. As a person who naturally speaks very fast, this takes time and conscious effort. In Learning Plan 9 this semester, we investigated the importance of healthcare workers and of preserving skin integrity. And while the changes that occur with aging may be inevitable, pressure ulcers are preventable. One important theme as we explore age-related changes is that if we know what to expect, we can better prepare ourselves. Therefore, We can embrace aging without the negative connotations. Just as aging comes with physiological senescence, such as impaired skin barrier, reduction in elasticity and strength, we must be aware of our own psychological attitudes as well. I learned that how my patients perceive their medical condition is reflective of how we help patients manage their new care and therapies. I think back to one of my patients, a post-surgical overflow in her late 50s. She was embarrassed by her involuntary stool excretions after having a sigmoid colostomy, and she made it difficult for caregivers to assist in her daily care activities, even hygiene and skin-related care. While our nurse's main focus at the time is on post-operative care, this experience reminded me that underlying psychosocial issues need attention first before our education can occur. Remember in pharmacology, in week 1, when we spent a lot of time discussing the importance of pediatric and lifespan considerations for medication administration? Well, the point here is exactly that. Our geriatric population, given their potential multiple medication use, or better known as polypharmacy, may influence how well they adhere to other treatment modalities such as pressure ulcer care. Sometimes polypharmacy can contribute to delirium, another issue for many elderly patients. Delirium is expensive. It is also a complex topic. I remember sitting in the geriatric program waiting at the edge of my seat, my hand raised, eager to ask a question. Why does your risk of delirium increase with aging? To my disappointment, and likely that of others, the answer is, we're really not sure. Yes, as of this moment, I still want to know. And so, despite the unknown, it is important that we are prepared to respond to delirious patients. I recall one of the falls on our unit in the past 6 months happened to a patient with delirium. She did in fact sustain a fracture, and of course, a fall can be tragic when you're older and prone to many health complications. Speaking of falls, at Aspirus, this has been an expensive challenge for us, and now, as a result, we've made a diligent effort to place bed alarms on most patients in addition to improving our signage, which reads, "Call, don't fall." The signs are fire alarm red in big and bold print and are an upgrade to earlier, less visually appealing signs. They also are much more prevalent on our unit. It is safe to say that you really can't miss the signs. They truly serve their purpose. What can cause falls? Well, pharmacology this semester reminded us of CNS depression with narcotic use, as well as the importance of assessing patients' level of consciousness and mental status. It should be no surprise that medication side effects can contribute to the risk of falls. Consider even diuretics and the patient's constant need to use the restroom, as well as the electrolyte imbalance risks with diuretic use. There is a safety concern with falling while in the restroom. So I know now that I need to monitor my patients more often and to make sure, for example, that assistive devices, as well as the call light, are in view. Nutrition and oral health was a really popular topic at the Geriatric Scholar Program because the speaker, also a dietitian, ordered a tray consisting of a variety of food options for those with dysphagia, my favorite being the turkey dinner, and how the dietary team shaped the pureed corn to look exactly like a corn on the cob. It was a neat experience to be not only a witness to what our dysphagia patients eat, but also to gain empathy by sharing the experience of what our patients exactly taste. Now, for the final topic and focus of my current effort and initiative, also by far my favorite lecture from the entire first semester. Urinary incontinence is an anatomical, physiological, cultural, and psychological issue. Due to its complexity and importance, I have chosen to connect incontinence to anticipatory rounding, a concept that's been around for decades. As a refresher, anticipatory or hourly rounding is a proactive process to meet patient needs and maximize staff responsiveness, in which staff, such as myself, are expected to visit the patient once every process and while doing so address the 5 Ps, a term we use to remember to address the patient's needs in each encounter. I will elaborate on the 5 Ps in a later slide. But before I do that, interestingly enough, I came across this quote in our Nursing Fundamentals textbook, and I had to share it with you not only for its truth, but also because 8 months ago, when I was applying for a position as a nurse's aide, I remember the first interview question. Tiffany, what do you think is the most important trait a nurse's aide can have? I answered, compassion and competence, just like Roach does here when he explains nursing. And now, having begun this project, I'm making the connection even more deeply. The issue of urinary incontinence involves imparting compassion as well as competent and safe patient management. For example, I remember a young woman in her 30s who was fighting breast cancer. Being young and able-bodied, she was really embarrassed when she discovered she had an episode of incontinence, likely due to chemotherapy-induced side effects and possibly an antiemetic that had a mild sedative effect when she was asleep. But for older patients, too, urinary incontinence can be embarrassing and can have other social consequences. Competence, of course, comes with knowing that urge urinary incontinence is associated with falls, especially when you have an elderly or ACE patient with reduced bone density. So we need to use both what we know socially and what we know about safety. Lacking the competence and compassion needed to understand and intervene may lead to overall complications in bed rest and immobility. Misconceptions about urinary incontinence still arise even among the most informed of staff. On a unit-wide level, I'm really impressed that we have learned to see that urinary incontinence does not mean that a patient needs a catheter. Our number of catheters, and of course catheter-associated infections, has dramatically declined, and I think this is in part because we are having this conversation now. I was sitting in my director's office and asked her about how we are doing unit-wide with catheter-associated urinary tract infections, and she shared with me a recent encounter she had with one of our oncologists. She overheard the oncologist talking with the family about catheter placement, and he stepped outside momentarily. The director suggested to the oncologist that maybe other alternatives would be possible, and to maybe see if the patient would prefer one of them. Acting on her recommendations, the patient was thrilled to opt out of catheter placement. So it is something we are really working on hospital-wide and are having conversations about. Back to the 5 Ps, which are pain, potty, position, possession, and periphery. A lot of benefits that come from their use, including increased patient satisfaction and reduced falls, are not only important for quality patient care, but also in terms of staying financially viable as an organization. As I was discussing the concept of 5 Ps with Shirley, one of our long-term clinical educators, she reminded me of an analogy as she explained some of the challenges with implementation. A lot of staff see anticipatory rounding as extra work and a task separate from other duties, but really, she says, Tiffany, it's like getting the mail. If you have to pass a medication, address the 5 Ps right then and there. To which she further added, you don't go out to get the mail and take just the junk mail. You go and get the mail all at once. Interesting, but very realistic example. So what does all of this mean for us as a class? Well, an opportunity for interactive learning. Based on Valerie's elimination lecture, in which she reminded me how much I enjoy the saying, draining the lizard, as an informal way of indicating a male needs to micturate, I decided to use that expression and simulate the reality of the challenge for me as I develop a project, because the truth is that day-to-day healthcare operations can be fast-paced and stressful. The game objective went as follows. You have 4 minutes to address the 5 Ps. Are you feeling better or worse? How is your pain? What can we do to make you more comfortable? Are you ready to use the bathroom? Are you able to get yourself to the bathroom? Can you reach everything, or can I help you get something? Do you have your call late, and may I bring you something? I have time. And your patient is an ACE patient who suffers from urinary incontinence. You have to bring your patient to the bathroom, but can you do it with all of the other influences that healthcare workers encounter daily? Can you, in 4 minutes, address the 5 Ps while simultaneously confronting the distractions that arise during patient interactions? And your patient is a simulated ACE patient. And the distractions are provided by your audience. So I was able to provide the audience with the tools to simulate such distractions, such as bike horns, sounds that imitated call lights, visual distractions, phones ringing, etc. Yes, having a classmate pretend to be an ACE patient and a nurse who is constantly bombarded by important distractions made for an interesting learning opportunity. But it is important, because before we can get to the solutions, we must put things in perspective and see safety through other lenses, the lens of the nurse, the patient, and administration. It is now my task to address this issue with my unit. Thank you for your time, and I hope you find the Learn Your Way activities as fun and important to professional development as I did. But, most importantly, good luck in nursing fundamentals.